Again, welcome to the OpenSim webinar. Today's presenter will be Julie Thompson, who's a postdoctoral fellow here at Stanford. She'll be presenting her work on simulating quadriceps muscle atrophy and activation deficits during Gait. Before we dive in, just a quick reminder about what the OpenSim project is and the goals of our webinar series. So OpenSim is a freely available software application for visualizing musculoskeletal structures and simulating movements of humans and animals. The application includes tools for general purpose inverse kinematics and dynamics. There are tools for optimization to estimate muscle and joint forces, methods so you can create simulations for motion capture data, as well as tools to analyze and visualize the results of your simulations. So the first goal of our webinar series is to showcase this cutting-edge research that's being performed with OpenSim. OpenSim is also a growing and geographically diverse community of users. So the second goal of our webinar series is to provide for members of the OpenSim community to communicate with each other and collaborate. Before we get started, I have a few reminders about the webinar format. Questions will be addressed at the end of the presentation using the Q&A panel. If you need any additional technical help, you can also consult the guide on our website. So let's get started, but before we do, I'd like to introduce our speaker for today. So Julie Thompson received her PhD in mechanical engineering from the Ohio State University this past December, where she was working with Dr. Rob Sisson in his neuromuscular biomechanics lab. Her dissertation focused on the effect of quadriceps weakness on lower extremity muscle function during Gait. Then in January, she began working here in the Human Performance Lab at Stanford as a postdoctoral scholar. Her interests include using experimental and modeling techniques to investigate the mechanisms relating muscle function, biomechanics, and patient function to help improve patient outcome and prevent injury. She's particularly interested in populations with knee injury and pathology. So in today's webinar, she's going to be presenting a portion of the PhD dissertation work. So with that, I'll let you take it away, Julie.
All right, thank you very much for the introduction, Jen, and thanks to all of you who are listening today. My work is motivated by the fact that persons with knee osteoarthritis experience significant quadriceps weakness, and this weakness is strongly correlated with difficulty performing everyday activities such as walking. So if we can determine how muscle function is influenced by weakness in the quadriceps and how other muscles might compensate for this weakness, then these results may help to inform and guide rehabilitation in the future that could slow disease progression. The objectives of this webinar are to first give some background on the prevalence of quadriceps muscle weakness, particularly in the OA population. I'll talk specifically about two different types of muscle weakness, atrophy and activation deficit. I'll discuss then the motivating questions behind the research that I'm presenting and how we address those questions using the OpenSim platform. I'll also give some methodological details of how we simulated weakness. And then I'll conclude with the major findings and takeaway message from the study that I'm presenting, which was published last year in the Journal of Biomechanics. So first, some background. Osteoarthritis, or OA, is a musculoskeletal disease that's characterized by the progressive deterioration of the articular cartilage of the knee joint. It's very common. There were nearly 50 million cases in the U.S. between 2007 and 2009, which was about 22% of the population. And this number is projected to increase to 67 million, or about 25% of the population by the year 2030. It's also been shown that 37% of individuals over the age of 60 have radiographic evidence of OA. So for example, if you look at the X-ray images at the bottom of this slide, you can see that on the right, this particular person has joint space narrowing, which is characteristic of knee OA. Approximately 21 million adults in the U.S. also report activity limitations due to the symptoms of their arthritis, and this can involve things like increased dependence and difficulty during everyday activities like walking and climbing stairs. Weakness in the quadriceps in particular has been linked to functional impairment, such as an increased fall risk and slower walking speed. And the quadriceps are a group of 4 muscles. They're located on the front of the thigh. They're important for support and stabilization during gait. It's also been shown that quadriceps weakness is one of the earliest and most common symptoms of OA. And there's really two sources of muscle weakness, or two types of muscle weakness that are really common in the OA population. One is atrophy, which is a decrease in the number or size of muscle fibers. And then the other is reduced voluntary activation. And this isn't so much a decrease in the size of muscle fibers as an inability to recruit or activate all the muscle's motor units. Previous work has shown that deficits in quadriceps strength can be quite high. Strength deficits can be as high as 38% in late-stage OA compared to normal healthy quadriceps, and can be as high as 64% after a total knee replacement for the treatment of knee OA. Activation deficits can also be as high as 34% in the OA population. However, the underlying mechanism relating quadriceps function to gait impairments remains unknown. Due to the complexity of the human body, determining the function of individual muscles is difficult to do with purely experimental techniques, which is where dynamic computer simulations come into play. They're a powerful tool for investigating cause-effect relationships, for example, how the impaired function of weakened quadriceps may be compensated by other muscles in the leg. They also allow us to determine the individual roles of muscles in coordinated movement, and can be used for predictive studies. So, for example, how muscle function changes in response to rehabilitation, surgery, or gait retraining. Now, when we look at how the human body produces coordinated movement during walking, there's really two major motor functions that we want to consider. One is forward progression, or forward acceleration of the body, and the other is vertical support, or vertical acceleration of the body against gravity. Previous research has investigated muscle function in healthy and some pathological populations, and these studies have found that the main contributors to progression and support during gait are the quadriceps muscle group, Gluteus Maximus, and the plantar flexors. They've also found that the force in these muscles generally increases with gait speed. However, less is known about muscle compensations in populations with weakened quadriceps, so for example in the OA population. So our work was motivated by a couple of questions. Do other lower extremity muscles compensate for weakness in the quadriceps? And if so, how? And also, do these compensations differ between the two types of weakness, atrophy and activation failure? So then if we can estimate muscle compensations in response to weakened quadriceps that are required to maintain normal gait, we can apply a similar method to investigating muscle compensations in pathological gait. So for example, in the OA population, and also perhaps individuals who have had an ACL injury or a total knee replacement. And hopefully these results can help to inform and guide rehabilitation strategies that can improve patient outcomes. The study that I'll be presenting today focuses on this part of the flow diagram. The purpose was to estimate changes in muscle forces and contributions to support and progression to maintain normal gait in response to two sources of quadriceps muscle weakness, atrophy and activation failure. We collected motion capture data in the OSU Movement Analysis and Performance Lab on 7 healthy subjects. We collected bilateral gait data from each subject walking on level ground at a self-selected speed. We used the full body point cluster technique marker set shown here. And we also did activity using surface electromyography from major bilateral lower extremity muscles. Our experimental gait data was then used to generate walking simulations of one gait cycle for each subject using the OpenSim software. And we also used the Gait 2392 model, which is a generic musculoskeletal model included in the software. And the diagram that's shown here is a typical workflow for creating a muscle-driven simulation of gait. And I'll just briefly describe each step in the diagram. First, we use a standing static calibration trial that was collected for each subject to scale the generic musculoskeletal model to match the size of the individual subject. And this uses relative distances between pairs of markers that are placed on anatomic landmarks. The experimental gait patterns were reproduced in each subject in the scaled model by solving an inverse kinematics problem. This used a weighted least squares approach to minimize the differences between experimental marker locations and the model's virtual marker locations. We then use something called a residual reduction algorithm, or RRA. This makes small adjustments to the model kinematics in order to resolve dynamic inconsistency that arises between model kinematics and experimental ground reaction forces due to experimental errors and modeling assumptions. And then we use computed muscle control, or CMC, to calculate muscle excitations and forces in all of our lower extremity muscles that produce a coordinated muscle-driven simulation of the subject's gait. This then is an example video of one of our simulation outputs from CMC. It's been slowed down for easier viewing. And like I said, it produces a muscle-driven simulation of the subject's movement. And I just want to point out in the video that hopefully you can see that the different actuators, which are representing the muscles in the lower extremity, are changing color between red and blue. And this is giving us an indication of when the different muscles are active. So if it's dark red, that means it's fully activated or turned on. And dark blue means that that muscle actuator is deactivated. So from CMC, we have information about how muscle forces are changing during walking. But we also wanted to take that a step further and see the role that each muscle plays in supporting the body and moving the body forward. So in other words, how it contributes to support and progression. And we can do this in OpenSim using something called an induced acceleration analysis, or IAA. And this uses foot contact constraints combined with equations of motion to calculate how much of the total acceleration of the body in the forward and vertical directions is coming from each muscle. So in other words, how much acceleration is caused by each muscle force that was calculated from CMC. After completing our full strength simulations for each subject, we then progressively weaken the quadriceps of one stance leg in 3 different ways. First, we simulated atrophy only. We did this by decreasing the peak isometric force of the quadriceps to 40% of normal. So if we look at a typical active force length curve per muscle, the black line represents the normal full strength simulation. When we decrease the peak isometric force of the muscle, that is effectively scaling the force length curve, which gives us the blue dashed line for our case of atrophy only. And that 40% value is coming from values that have been reported in previous literature as a worst case scenario of atrophy in individuals that have quadriceps weakness. Next, we simulated activation failure only, and we did this on a subject-by-subject basis by decreasing the peak activations of the quadriceps muscle by 35% compared to the full strength simulation. And again, that 35% value is reflective of the high end of values that have been reported in literature. So for example, if we look at the vastus lateralis muscle of one of our subjects, we first calculated the peaks of the normal full strength activation, which is the black line. And then we constrain those peaks to be 35% less than the normal simulation, which gives us then the red line representing our case of activation failure. And then finally, we simulated a combination of atrophy and activation failure. For each of these weakened cases, we reran the CMC and IAA algorithms while tracking normal gait kinematics and recalculated muscle forces and contributions to progression and support. So I'd now like to give some more details on how we actually did this in OpenSim. So first I'll talk about how we simulated muscle atrophy using our vastus lateralis muscle as an example from one of our subjects. We see that the value for the peak isometric force in the generic model is 1871 newtons. So from here, it's really a simple calculation to determine the new peak force value by decreasing this to 40%. So in this case, that gives us a new value of 748.4 newtons. So then one way to prescribe this new value is to adjust the max isometric force parameter in the model file. You can do this by editing it in a text editor. I like to use Notepad++, which is what is displayed here. And you can see that there's different parameters listed for each muscle. So then we would just find our muscle that we want to edit, in this case, vastus lateralis, locate the max isometric force parameter, type in the value that we want it to have, and then save that edited file. You can also adjust this parameter in the OpenSim GUI directly. So when you load your model into OpenSim, it'll show up in the navigator window along with the different components of model by clicking on the plus sign next to the model name and then clicking on the different plus signs that are next to the model components. You can expand the model tree to get to the components that you're interested in. Hello? Testing? Okay, sorry, I lost the sound for a second. So then clicking on the vastus lateralis muscle and editing that max isometric force by hand, we can make edits in the GUI and then save it directly through the GUI. And just to note, atrophy, the way that we simulated atrophy was constant across all of our subjects because we were using the same generic musculoskeletal model, and the default peak force for the quadriceps in this generic model is the same for all subjects. However, simulating activation deficit was specific to each of our individual subjects, and so it was a little bit more of an involved process. We chose to constrain peak activations for each of the quadriceps muscles on a subject-by-subject basis instead of applying an overall constraint on the muscle activation. And we did this because the quadriceps are never maximally activated during gait, so applying an overall constraint on the maximum activation wouldn't have resulted in any actual simulated activation deficit. And I'll explain a little bit more about the pros and cons of this approach in the discussion at the end of the webinar. So again, using the right vastus lateralis muscle of one of our subjects as an example, we first plot the activation for the full strength simulation, and then we use some simple custom MATLAB code to determine the values and locations of the peaks in the activation. It's then, again, some simple calculations to determine what the new peak values for activation would be when we decrease these to 65% of their full strength value. In other words, applying a 35% deficit. So for the first peak, then, the new value would be 0.259. For the second one, our new value is 0.114. And then in between those peaks, the muscle is basically off and not activated. We then use these values to apply constraints to the muscle excitation in the control constraints XML file, which is one of the settings files that's used by CMC, which specifies the limits on the model actuators. It can also be edited in a text editor, such as hello? Testing? Okay, sorry, we're having problems with sound here. So anyway, we using an array of paired time and control values, or nodes. These values are linearly interpolated to determine the value of the control at a particular time. The value associated with a node is applied before the specified time. So in other words, when interpreting a control and its constraint, or its min and max value, it's the value from the future node to the present node that's applied. And so it really helps to visualize this in the excitation editor GUI, and I show a screenshot of it on the right side of this slide. So if you load the control constraints file in the excitation editor, you can then select the muscle of interest, for us, the vastus lateralis, and it'll display the nodes that we specified in that control constraints file. And this makes it easier to see how they're connected in constraining the excitation of that muscle. After applying the appropriate constraints to the muscle excitations and saving that new edited XML file, we can then, in the CMC tool in the GUI, specify this new constraints file in the actuator constraints box on the main settings tab, and then run CMC as normal. It's important with simulations like this to check the quality of our simulation output by evaluating the results in a couple of different ways. Particularly when it comes to CMC, it's a good idea to check the activations that are output from the simulation with experimental EMG data if you have it. It's also a good idea to check the coordinate errors and also residual forces and moments from the simulation. So for us, we considered our results from RRA and CMC to be acceptable if the model kinematics differed from experimentally measured kinematics by less than 2 degrees or 2 centimeters for translation, and if the peak residual forces and moments were less than 20 newtons and 50 newton meters, respectively. And this is really based on suggested best practices in the online OpenSim documentation. So then moving on to the results from our study, this table gives an overview of the findings for the different muscles that we investigated, and I just want to highlight a couple of things. First, the numbers that are shown in this table are averaged across our 7 subjects and also over all types of weakness. And what I want to first draw your attention to is highlighted in yellow are quadriceps muscles. As expected, since we were weakening these muscles, we found that the force and contributions to progression and support decreased for these muscles. Interestingly, we found that to gait kinematics, the Gluteus Maximus and soleus muscles displayed the greatest ability to compensate for weakened quadriceps by being the only muscles which increased their peak force output and peak contributions to progression and support for all types of quadriceps weakness. So then looking at those 2 compensating muscles in a little more detail, first looking at the Gluteus Maximus force output. This plot is showing force output with respect to % gait cycle. Each of the lines is averaged across all 7 subjects. Black line represents the normal full strength simulation. The red line is for the case of activation failure only of the quadriceps. Blue line for atrophy only, and then green for the combined case of atrophy plus activation failure of the quadriceps. And what we see for Gluteus Maximus is that it generates more force in early stance and compensates more in response to the combined case of atrophy plus activation failure. We saw an average peak increase of nearly 3 newtons, which was a little over 40% change from the normal full strength simulation. Looking at the force output for the soleus muscle, we saw that it compensates and generates more force in late stance. And interestingly, we saw that there was greater compensation needed to overcome the activation deficit of the quadriceps, with an average peak increase of a little over 217 newtons, or 13% increase over the full strength simulation. If we move then to looking at how these muscles compensate in terms of their contributions to progression and support, first looking at the Gluteus Maximus muscle, the normal function of this muscle is to provide braking and slowing forward progression of the body in early stance. So we see that when it's compensating for quadriceps weakness, it's basically doing more of this. So it's contributing more to slowing forward progression, a nearly 46% increase over the normal full strength simulation for the case of atrophy plus activation failure. And it's also contributing more to maintaining vertical support in early stance, a little over 32% increase. The soleus muscle, the changes in compensation in soleus were not quite as large as Gluteus Maximus, but we did see that the soleus contributes slightly more to maintaining forward progression in late stance, about a 7% increase over the normal full strength simulation, and also the compensation was greatest for the case of activation failure only of the quadriceps. And similarly, it contributes more to maintaining vertical support in late stance, about 12% increase over normal. So in conclusion, we believe that this is the first study to develop muscle-driven simulations investigating the 2 sources of quadriceps weakness that are common in the OA population, atrophy and activation failure. We found that to maintain a normal gait pattern, the Gluteus Maximus and soleus muscles showed the greatest potential to compensate for weakened quadriceps. And we saw that these 2 muscles responded differently to the different sources of weakness, which may highlight the importance of addressing both types of weakness and rehabilitation strategies. Our results should be considered in light of several limitations. One is that we forced all of our simulations to track a normal gait pattern, but we know that persons with OA often do not use a normal gait pattern. So this common finding of abnormal gait in persons with pathology suggests that there are probably compensation thresholds beyond which an individual will choose to adapt and alter gait patterns instead of just increasing muscle normal gait. However, we believe that our results offer initial insights to what compensation strategies may be needed for a person with weakened quadriceps to maintain a normal gait pattern. As I mentioned in the methods, we applied activation failure in our simulations by constraining the peak values of the quadriceps activations instead of applying an overall constraint on the maximum activation. To our knowledge, no study has investigated whether activation failure influences performance of submaximal activities such as gait. So while our approach to applying quadriceps activation deficits hasn't been validated through physical experiments, and may not necessarily reflect in vivo activation deficits, we believe that it represents a key step in investigating the effects of activation failure during walking, and also utilizes the strengths of simulations in answering what-if questions related to muscle function. Our simulations also used a generic musculoskeletal model, which may not be entirely applicable to populations with weakened quadriceps. Given that the amount of atrophy or activation failure present in populations such as the OA population can vary a great deal between individuals and can also depend on factors such as disease severity, we chose to simulate what may be considered the worst case for populations which commonly exhibit quadriceps weakness based on values that were reported previously in the literature. So this leads then to future work and the importance of future work on simulations of pathological gait, which incorporate patient-specific muscle properties to accurately quantify variations in muscle function in impaired populations. In fact, a recent webinar by Jill Higginson, Brian Nahr, and John Ramsey discussed this topic where they measured and incorporated subject-specific muscle properties into simulations of post-stroke gait. In my own dissertation work, we performed a pilot study in which we measured and incorporated patient-specific muscle properties of an individual's knee OA. That work is currently being prepared for journal submission. Future work with individuals with pathology then will hopefully expand on these results and determine individual compensation strategies that can be evaluated through clinical interventions. So finally, then, a quick take-home message. Our initial findings suggest that Gluteus Maximus and soleus may be potential targets for strength training during rehabilitation. Understanding compensation strategies that are necessary to maintain normal gait provides a foundation to investigate the role of muscle weakness in pathological gait. The methodologies that I presented here are just one example of how we leverage the OpenSim platform to begin to address this important topic. Finally, like I mentioned in the objectives, this study was published in the Journal of Biomechanics last year. So if you're interested in reading in more detail about the results, then I'll direct you to this paper reference. I've also listed my contact information, my email address, so feel free to email me if you want to discuss the study in more detail, and hopefully I can answer any questions that are not addressed in the webinar today. And finally, I want to acknowledge the co-authors on this study, as well as OSU staff and students, and also past and present members of the OpenSim team who have helped me with this research, as well as my funding sources. That's it. Thank you.
All right. Thanks, Julie, for a great talk. It was super clear and also a really cool application of modeling and simulation. Thank you, all of the listeners, for bearing with us with those little technical difficulties as well. Now is the part where we get to open it up to questions from the audience. All of the questions will be text-based, so you need to find the Q&A panel in your WebEx controls. You select all panelists and then type in and send your question. Let's see if any questions have come in. Looks like people are still typing them in, so I'll go ahead and ask a question to get started. I was wondering if you, I guess, with the quadriceps muscle forces going down, whether due to atrophy or activation failure, you would think that would reduce the joint loads. Mm-hmm. Did you look and see in those cases where you simulated the atrophy and activation failure and the gluteus maximus and soleus compensated, did the knee joint loads actually go breakdown?
Yeah, so that's actually an excellent question. We didn't investigate knee joint reaction forces in this particular study, but we did investigate joint loads in our follow-up study of incorporating the subject-specific muscle properties in an individual with knee OA. And interestingly, for that one particular OA subject, like I said, it was a pilot study, we didn't see big changes in the magnitude of the knee joint reaction forces between the generic model and the model that was tuned to reflect the specific muscle properties of our OA subject. But we did also then kind of move forward from there and do something like a virtual gait retraining simulation where we force our weakened model with the subject-specific OA muscle properties to track healthy gait kinematics. And we actually did see some changes in joint reaction forces there. We actually saw that for the simulation tracking healthy gait, there were slightly higher joint reaction loads than in the simulation tracking OA gait kinematics. And then some of my colleagues at OSU even took that a step further and ran some simulations where they strengthened the quadriceps muscle group in one model and then also strengthened the gluteus maximus and soleus muscle groups in another model, forced those to track OA gait kinematics and healthy gait kinematics and looked at the joint reaction forces there. And again, they saw that joint reaction loads were a little bit higher in the healthy simulations and actually were a little higher for the simulation that had quadriceps strengthening and were reduced in the simulation that had strengthening of the compensating muscles, gluteus maximus and soleus. So again, those are just initial findings, but I think it's interesting because it might suggest why individuals with knee OA might adapt an altered gait pattern if this helps to reduce the loads in the knee because it's higher if they're tracking a healthy gait pattern. And it's also interesting that they found that strengthening just the quadriceps led to higher knee joint loads. We know that in individuals with knee OA that they'll often avoid using their quadriceps, and one reason might be that they're trying to offload their knee joint. And so then increasing and strengthening those compensating muscles then might help to reduce that joint load.
Okay, great, thanks. We have a question from a member of the audience. Susan Sigward asks, so you use the worst case scenario for weakness in your simulations. Do you have any idea what the minimal deficit needed for eliciting a compensation?
That's a really good question. So in this study, yes, we just looked at worst case. So we didn't kind of do like a systematic study where we looked at lower levels of activation and atrophy. So I couldn't say with any, I couldn't say definitively that, you know, a 10% atrophy or something would elicit changes. But I do believe that there have been some previous studies that looked at the sensitivity of doing some things like muscle force and there in particular. I don't know if you lost it.
Where did you lose it?
At the beginning of the question. Oh, can you hear me now? Okay. Sorry, we had audio difficulty again. I'm not sure what got cut out, but what I was saying is that there was a previous study where they looked at the sensitivity of model predictions to changes in some of these parameters that I looked at also, in particular, adjusting peak isometric force and a couple of other parameters. And I believe they just looked at changing by 10%, so like weakness of 10%, and saw that that didn't change their simulation output significantly. So whether higher than 10% and less than 40%, which is the level of atrophy I looked at, would change things, I guess is something that I can't necessarily answer based on my study, but I think it's possible that you would see changes with some lower levels than what I looked at, possibly 20 or 30%.
Okay, audience members, please feel free to go ahead and type in more questions while we're, oh, I guess there are some more that didn't go to all panelists. Okay. So here, but we missed. So did you reduce the activation with the same percent as that used for that? So we simulated an atrophy of 35, because based on literature, 35% was really the highest amount of activation deficit that had been reported for these individuals, whereas some slightly higher amounts of atrophy, muscle atrophy, have been reported in this literature. So no, the values were a little bit different. Okay, great. Thanks for getting to that question, Julie. The next question is from Nathan Brown, and he asks, how did you determine subject-specific muscle activation over time?
So I'm guessing that what you mean by that is how we construct it like over time for each subject. And the way that we did that is that we first plotted the activation for the muscle for our full strength case. So we basically had like a time for the trial, and we used some MATLAB code then to detect the locations of the peaks were occurring. So when we were constraining our activations in the control constraints file, when we have those different time nodes, I can basically say from this time to this time, we want to constrain the peak by this value. So basically it's just looking for each subject during that trial, the time when we want to constrain the peaks based on when those peaks were occurring.
Okay, so Ching has a question to his original question. So he was asking about whether the percent difference was the same for the activation and atrophy. So following up, do you think the difference between the effects of the two simulations is due to the difference in the percent change?
Yeah, that's a really good question. So I think that our results were certainly sensitive to the values that we chose. However, I think a good explanation for why I don't believe that the changes were just due to the differences in numbers is the fact that we saw greater compensation for activation deficit in the soleus. And the reason I think that's interesting is because our level of activation deficit was smaller than our level of atrophy. So the fact that the soleus, though, even though activation deficit was smaller, was still showing greater compensation in response to that weakness as opposed to the combined case, I think suggests that there's something else going on there besides just the difference in the values that we chose.
Okay, we have time for a couple more questions. If anybody wants to get a last question in, I'll ask another question. So your results seem pretty promising that, if you strengthen the soleus and gluteus maximus, you would enable someone with OA to walk with a more healthy gait pattern. Do you know, is anyone pursuing a study to determine if that actually works, or how might you go about doing that?
As far as I know, no. Although my colleague Zach at OSU, I think there was talks that maybe they would carry that forward, some of the other students in the lab and the people there. I think that it would be really interesting and a really good validation for these simulations, for example, to then have that actual physical experiment. So I think a way to do that then would be to just recruit some individuals that actually had knee osteoarthritis and who are displaying quadriceps weakness and take them through a rehabilitation exercise program where we targeted gluteus maximus and soleus, and then see how that changes things. Measure them in a motion capture lab, see if that actually changes their gait patterns. So I think that could be one way of actually seeing if the predictions from our simulations would actually hold true in an actual patient.
Okay, Well, great. I think we'll go ahead and wrap up here. I also want to acknowledge our funding sources. So OpenSim and this webinar series are supported by several grants from the NIH, including an NIH grant that funds our National Center for Simulation and Rehab Research. We're also supported by DARPA and the Warrior Web effort. I really want to thank everyone for a great discussion. All of the questions that you guys asked were great. It's cool to get a discussion going across the world about OpenSim and OpenSim related research. So you can find information about our center, new OpenSim software releases, upcoming events, and other resources on our website. That's opensim.stanford.edu. And we also ask that you please complete the survey that's going to appear in a pop-up window at the end of the webinar. This will help us improve the webinar series and choose upcoming topics. So thank you again to Julie and to all of the audience members for tuning in. We hope you'll continue to stay involved with OpenSim.